Doctor, we are live and recording. You can start.
I'd like to say hello to all my friends in India and thank you very much for the honor of being able to give this talk with you today. I hope I'll be able to give you a new perspective on PCOS and what we can do to try and make the lives of our patients so much better. This is what I'm trying to achieve in the talk today. Firstly, to discuss with you the range of presentations that we see of PCOS, understanding that it's not one disease. Secondly, to discuss how the causes of ovulation relate to the etiology of the condition. Then to talk about the best options for ovulation induction. To present evidence-based approaches to fertility treatment. To increase your knowledge and the knowledge of patients regarding PCOS. And I'll be sharing a lot of our experience internationally and from Australia in terms of what we've learned about this condition. So let's start off and talk about PCOS generally. And many of you will know much of the features here, but I think it's important to lay the foundation of this talk by understanding what PCOS is. It's a very prevalent and a complex condition, the commonest hormone condition of young women, and certainly from my experience of your skills in India, something that you deal with on a regular basis. We think its prevalence is between 8 and 13%, and it has a very significant health and economic burden, in addition to the psychological pressures that come on patients. As we see the increasing burden of obesity, we understand that many patients are very unhappy with our care. There's often long delays in diagnosis. They have a poor experience with doctors who seem to know little about PCOS. Many of our patients have emotional needs that are underappreciated, and the metabolic risks are often not recognized. Added to that is the fact that there's very little patient information available. Much of it comes from commercial sources of clinics that want to see patients to do IVF, and much of this is inadequate. And lifestyle management is very limited because we don't make much money as doctors out of it, and we're not very good at it. So for us as health professionals, we need to become more consistent in our management. We need much better education and support. And we need to try and get some evidence-based guidelines that will help us decide what is true and what is not. So I'd like to remind you where we sit with the diagnosis of PCOS. Historically, in blue, we have the original NIH criteria, which demanded irregular cycles and evidence of hyperandrogenism with the exclusion of all other etiologies. The Rotterdam criteria has expanded this by looking at polycystic ovaries as one of the conditions and demanding 2 out of 3 of irregular cycles, hyperandrogenism, and polycystic ovary. But we still have the demands of exclusion of other etiologies. Now, once we expand the criteria, as we did in Rotterdam, we include many more patients in the community with PCOS. And this is a study of a group that we did at a hospital in Adelaide, where we were able to determine whether patients had all these conditions or not. And you'll see that if we use the NIH criteria, that about 9% of them had PCOS. If we use the Rotterdam criteria, up to 18% had PCOS. And there's another subgroup, which is called the Androgen Excess Society definition, which I'm not going into, and they fit in halfway between. So the definition is important. And if doctors are using different definitions, patients are going to get different diagnoses. We want to really push the Rotterdam criteria, and the PCOS Society of India, which is one of the really best societies in the world, has clearly come down with the Rotterdam criteria. So I would encourage you to use that. So if we look at PCOS across the world, even though we use the Rotterdam criteria, we have very different presentations. So in East Asians, so that's Chinese, South Koreans, Japanese, we see a lot of metabolic problems, a lower BMI, and much less hirsutism. In South Asians, particularly in India and Sri Lanka, Bangladesh, we see a very high prevalence of insulin resistance and metabolic syndrome, a lot of obesity, and a lot of hirsutism. And in Europe, we get a relatively milder phenotype. So even though we're using the same criteria, and as I'll show you in a minute, the same genetics, we get different presentations, and we need to be prepared to see that in our patients. So we have built a consortium around the world to come together with education and evidence-based guidelines. So we've involved 37 societies, including the ASRM, ESHRE, the Chinese, Indian groups, FIGO, WHO, and we've gone through the literature with knowledge synthesis and systematic reviews. We've developed translation activities, we've developed international awareness and evidence-based guidelines. And much of the talk that I give you today is based on our work in this area, in which many Indian physicians have made a great contribution. So what are evidence-based guidelines? Well, it's important to realize that they're not just from the literature and Cochrane. So evidence from research is incredibly important, and all of you will understand that there are levels of evidence that we accept, including randomized controlled trials. But in addition to that, we accept clinical expertise. So people's experience as doctors counts, and that is also taken into consideration. And then we have the consumer perspective. So the patient is incredibly important. What they want and what they're prepared to do is important. And finally, cost effectiveness. Whatever we decide on evidence-based practice must be worth it. It must be worth the money, and preferably cost very little. This is what is evidence-based practice. And this is what we have to incorporate into our understanding of PCOS. So let me take you first of all to how we should assess patients that we think might have PCOS. And our guidelines show the following. The first step is if a woman has irregular cycles and clinical hyperandrogenism, so that is hirsutism, she has PCOS, provided we've excluded other causes. If one of those features is missing, then we can go to measure the blood using biochemical hyperandrogenism, usually testosterone. If we have raised testosterone and we have irregular cycles, there's no need to do anything else. We've made the diagnosis. If, however, after excluding clinical hyperandrogenism and clinical hyperandrogenism, we still don't have a diagnosis, we go on and do an ultrasound. And the ultrasound may provide the second criteria that we need. But it's very important to recognize that ultrasound is not valuable in adolescents. Many adolescents have got polycystic appearing ovaries, and they only settle down when they get to the age of 20 or thereabouts in terms of the ultrasound appearance. So ultrasound has a role, but usually only after the age of 20. And I'd like to remind you that there are many other causes of irregular cycles that we need to investigate. Some of them are rare, some of them are much more common. So the importance of irregular menstrual cycles is illustrated in these diagrams. Red is irregular cycles and green are regular. So if we look at a young woman or young girl in her adolescence, 1 year after her first period, the majority of her cycles are anovulatory. After 3 years, about 60% are anovulatory. And when we get 6 years, about a quarter are anovulatory. And so we often have to wait a while to be sure whether anovulation is occurring. If you look at a woman who's been diagnosed at PCOS later in life and try and work out what her periods were like when she was a teenager, you'll see that the majority of these patients had irregular cycles, but some of them had quite normal cycles during teenage years. And so we need to allow for reproductive maturity often before making the diagnosis of PCOS. So we talked about periods. Let's just talk about measuring biochemical hyperandrogenism. So our guideline says that you should measure testosterone and probably SHBG if you can afford it to get a free androgen index. So this is the best way of going to get a free androgen index or a bioavailable testosterone. The second thing that we're saying is that if it's available, you should use a system such as liquid chromatography mass spectrometry as you get more reliable results for the testosterone. However, many clinics do not have access to this, and we have to rely on the standard methods that are automated for testosterone. And then we talk about polycystic ovaries on ultrasound. So I've said that we should be aware of using this in adolescents because of the high false positive rate. As we get better and better machinery, we're going to see more and more follicles. And so what we're recommending now is that we should move the number of follicles that are seen on ultrasound up to greater than 20. And if you can't see that very clearly, you can take an ovarian volume of over 10. So this is the new criteria, and it probably will change as our equipment gets better. I'd like to remind you of what I said earlier, but if you've got irregular cycles and high androgens, then an ultrasound is not important for the diagnosis. However, if you want to get the complete phenotype, then you would do an ultrasound. I'd like to end up this section by talking about AMH, anti-Müllerian hormone, because this may become a diagnostic substitute for ultrasound in the future. So PCO is characterized by a very high ovarian reserve. So if we look at this diagram here, these are the number of antral follicles, and you'll see that they're much higher in PCOS than they are in controls. If we measure AMH, which is a hormone that we all use for IVF assessment, you'll see that it's very much higher in PCOS as compared to controls. And so some people have advocated that we should stop doing ultrasound and we should just measure AMH as a substitute. However, AMH at the moment is still not the greatest test for ovarian ultrasound substitution. The problem is that we've got different assays, we don't have an international standard, and there are a number of interferences in the AMH methodology that we haven't solved yet. However, I expect in the next decade, we will definitely use AMH for the diagnosis, and the use of ultrasound will become much less. Right, having discussed the background to PCOS, let's just look at the reasons now for anovulation and how it might relate to the cause. So I'd like to remind you about the menstrual cycle, something that you will all know extremely well, whereby the hypothalamic pituitary region communicates with the ovary to produce LH and FSH, and there is substantial feedback from the ovary through estradiol, progesterone, inhibin, and other hormones that regulates the cycle so that it comes on a regular basis and that ovulation occurs. So this is what we're looking for in a woman who is having regular ovulatory cycles. And we know that in polycystic ovary syndrome, that there is a gap here at around about 5 to 6 millimeters where the follicle doesn't proceed any further. And that is the cause for ovulation. So the cysts that we see are actually follicles. All of them have got eggs in them. We can extract eggs from them, we can mature them, and we can get babies from them. The term polycystic ovary is not a good one, but cannot be replaced at the moment. So this is what we see in the ovary. We have a range of follicles ranging from very primary ones through to much maturer granular cells around it, a secondary follicle, and then a follicle that's about to ovulate. And at different stages, we have different levels of receptors for FSH and LH and different levels of estrogen being produced. All of you will know that you need normal nutrition for reproduction and that the fat cells produce adipocytokines and the pancreas produces insulin. And so we have a vast array now of metabolic signals from fat that interfere with the pituitary hypothalamic axis, and that we know that insulin can have a significant effect on the ovary and also on the brain. We need normal nutrition to get appropriate puberty and regular periods and normal fertility. And when this gets disturbed, we get infertility, miscarriage, and an abnormal pregnancy. So if we look at the current causes of PCOS and the theories behind them, we have a number that we can look at and see how that relates to our patient. First of all, it's genetic. There's a very big expansion in genetic testing now, but we think that probably we can only explain about 10% of patients with PCOS on known genetics. I want to tell you something about new results on AMH and how that may relate to PCOS. We all know about insulin resistance and how that may cause or aggravate the condition. Increased androgens given to women lead to polycystic ovaries. And there are many animal studies that suggest that this may be the cause of PCOS. Interuterine events can also program the ovary, and there are a number of animals where we can show that we can cause PCOS by giving excess androgens to the mother in pregnancy. And finally, there are new concepts about the way that the hypothalamus senses progesterone that may explain PCOS. So this is the general concept we've got at the moment. There's a genetic cause to PCOS, which we don't really understand. There's a lifestyle element, particularly obesity, and that these combine to lead to hormonal changes that affect androgens, hair growth, high insulin, diabetes and cardiovascular risk, and the reproductive consequences that we see with ovarian follicles, anovulation, and a raised estrogen condition. And this leads to menstrual disturbances and infertility. It's very important to recognize now that psychosocial consequences flow from PCOS, and therefore that is something we need to address. So we can look at all of these aspects and see, could they explain PCOS and why anovulation occurs? And are there things we can do to remedy them? So just to remind you that PCOS is a condition with reproductive, psychological, and metabolic sequelae, and we need to address all three of them to get a good fertility outcome. Let's look first at insulin resistance in PCOS. Almost everybody is insulin resistant who has PCOS, even the thin patients. And I know that we're all very keen to try and measure insulin resistance by measuring insulin or the HOMA-IR test, but they're actually not very useful measures. And we should really make the assumption that any patient in whom we diagnose with PCOS is insulin resistant. And this has consequences on fat tissue, muscle, the bowels, the ovary, the hypothalamus, pituitary, and also the liver. And so one of the things we're trying to do is to lower insulin resistance and get insulin sensitivity into the patient we're treating. The insulin resistance is manifested in diabetes. And we know here that the prevalence of diabetes is at least 4-fold in patients with PCOS, and gestational diabetes is particularly increased. So our therapeutic goals for patients to try and get them to ovulate is to deal with their metabolic syndrome. We have abdominal obesity, poor activity, bad diet. Some people smoke, high cholesterol, high triglycerides, high blood pressure, increased glucose, increased coagulation. And we've got certain aims that we're trying to get to, and there's various therapies. And these will be well known to you, and I don't intend to go through them in detail today. But they have a mixture of lifestyle and drug interactions. So the cardinal feature of trying to reduce insulin resistance is to get lifestyle changes. And that includes exercise and good diet. And so a good diet is basically a lower calorie diet than they're eating at the moment. And good exercise is to try and get at least 150 minutes of walking or simple exercise throughout the week. So diet and exercise is cardinal. What about drugs? Well, metformin has been used for a very long time to try and lower insulin levels, increase insulin sensitivity. And we know that this improves the concepts of diabetes and also improves ovulation. So this is an extremely safe drug with minimal side effects other than gastrointestinal, and is something that is widely used. There's been a lot of discussion about myo and D-chiroinositol, and I know that you use these drugs very widely in India. We've not got a wide experience in Australia of them, but they are drugs that are cheap and widely available. They do have a very good physiological basis, and they're probably free of side effects. However, there's a relatively poor lack of trials. If you look at the Cochrane collaboration report, it is mainly positive for both chiro and myo-inositol. And you'll see here the relative benefits, 2.32 here for myo-inositol, and 3.13 for chiro-inositol. If you compare them with versus placebo, particularly myo-inositol, there seems to be some benefit. And if you compare myo-inositol against placebo here, you also get a benefit. So this is a drug that I think these are drugs that need to be looked at much more detailed than has been so far, but there is certainly promise. So lifestyle, metformin, and some form of inositol may be valuable. Let's look at the genetics now. So there is a genetic basis for PCOS, and this is a Dutch study that looked at identical twins, monozygotic twins, and dizygotic twins, and noted that if you're an identical twin, that you were more likely to get oligoamenorrhea if your other twin had it. So there's a very good concordance of menstrual cycles between monozygotic twins and not so good concordance for dizygotic twins. The same occurs for hirsutism. If you're a monozygotic twin and your sister has a lot of hair, so do you. However, if you're a dizygotic twin, it's much less likely. And it's the same with acne. Now, this is a complicated graph, and it's called a Manhattan plot. And it's just a way of looking at genes that occur in patients with PCOS. So various groups around the world have got together around about 40,000 patients with PCOS on whom they've done genetic studies. And they've tried to compare PCOS patients versus normal patients. And using a cutoff, which is very, very significant at this green line, any of these above the green line are highly significant in PCOS. And you'll see a whole lot of names that you've never heard of before, and they're related to the number of chromosomes at the bottom here. So some of these have come up consistently across East and South Asians and Westerners, and we think are significant. So I'm not going to go in detail about the genes, but just to show you here that there are some genes that relate to gonadotrophins. So these particular genes, FSH receptor, beta, LH receptor, seem to have something to do with gonadotrophins. There are other genes to do with the ovary, and these are genes that have never been experienced in the ovary before, but we're now discovering what they do. There are other genes that deal with insulin resistance, and there are other genes for which we have no idea at all. And so basically we're getting more and more information about the genes, but as I said at the beginning, less than 10% of patients with PCOS would have any sort of genetic explanation using these particular genes. There's another genetic explanation for some forms of PCOS, and that is that there is a particular change in the gonadotrophin in one particular region, and patients may have asparagine or asparagine serine or serine in that particular site of the FSH or LH molecule. And some Dutch investigators led by Joep Larven have shown that ovulation is quite different depending on what sort of gene the patient has in that particular area, which particular amino acid. This doesn't explain why some patients don't ovulate, but as we look more and more into the genetics of the gonadotrophins, we may discover more patients who respond in a different way by understanding their genetics. And then I want to talk about AMH in terms of follicle development. So I've talked about AMH before being increased, and we see it expressed in the granulosa cells of the ovary. But AMH appears to stop the conversion of androgens to estrogens and is expressed at a very early stage of follicle development. It's not expressed so much in the pre-ovulatory follicle as in the primary follicles. Some really exciting information has arisen in the last couple of years, whereby we no longer think AMH is just an ovarian hormone, but it seems to circulate, and people have discovered AMH receptors on the GnRH neurons in the hypothalamus and pituitary. And we now think that AMH circulates and that it affects the GnRH pulsatility. And there are many experiments now in mice that suggest that AMH in very high levels stops good pulsatility of GnRH and therefore is associated with polycystic ovary syndrome. And so this is the model that we're thinking of at the moment, is that if you've got lots of follicles in the ovary, you produce lots of AMH. That AMH affects the pulsatility of LH and FSH from the pituitary gland, and that in turn leads to increased hyperandrogenism, a higher progesterone, which affects the GnRH release, and stops the follicles growing through properly. So we get anovulation. One of the theories is that AMH increases androgens in the placenta, and that a woman with PCOS may have very high AMH that affects the placenta and leads to increased androgens. And that leads on to this fetal origins of PCOS. There's a strong view at the moment that PCOS has its origins in fetal life, and that as the ovary develops, so abnormality that leading to polycystic ovaries is also found. So there are many animal models giving testosterone to pregnant animals that leads to polycystic ovary-like conditions. We think that AMH may have a potential role in the ovary, and that ultimately this leads to more fat, more insulin resistance. And we actually know that we can pick up children who are prone to get polycystic ovaries by just measuring their AMH early in life, long before puberty. So let's now move to evidence-based ovulation induction. We're looking for assessment of ovulation. Cycles between 21 and 35 days are usually quite adequate. We need to remember that ovulation occurs 14 days before a period, and many women know when they're ovulating. Progesterone should be taken 7 days before a period, and sometimes weekly blood tests for progesterone is valuable. Temperature charts are less useful, salivary testing is hopeless, and urine testing for LH is quite good. We need to recognize that if we can get on top of the metabolic risk, we can improve ovulation. So we need to measure weight and BMI regularly, look at the glucose, do blood pressure, and lipid screening. And we need to remember that glucose assessment could be hemoglobin A1 or an oral glucose tolerance test. We need to remember emotional well-being. As I've said before, this is often very poor. And if we can improve that through psychological help, we'll get a better ovulation induction outcome. So there are many drugs that we can use for ovulation induction, as I've shown in this particular screen. And we need to work out which ones should we use first. Well, this is our review of the literature, which is now accepted as part of the International Evidence-Based Guideline. Lifestyle intervention first, followed by letrozole. Clomiphene is a good second option. Clomiphene, citrate, and metformin is good. So is metformin. And if they fail, gonadotrophins or laparoscopic surgery. And if they fail, IVF can be useful. So clomiphene citrate's been used for more than 50 years, and this is what we would expect to see using clomiphene citrate. That as we increase the number of cycles, so the number of pregnancies is going to increase. And so at 6 months, about 60 to 75% of patients will be pregnant. It's still an excellent drug. However, if we look at those patients who are relatively thin, metformin can give you almost the same result, and possibly inositol could as well. And so this is a study, a Cochrane study, that basically shows that metformin versus clomiphene citrate for thinner people gives you a good result. Letrozole is now the #1 choice. And I know that letrozole has a checkered history in India, and I'm not sure whether you're using it at the moment, but there is no doubt that it is superior to clomiphene citrate. So this is the famous study by Legro, looking at clomiphene versus letrozole, and looking at those patients who ovulated and the total number of ovulations. And letrozole is clearly superior to clomiphene citrate. It also leads to less multiple ovulation. And in his paper, Legros showed that the cycle pregnancy rate was much higher with letrozole than it was with clomiphene citrate. And this, together with many other papers, leads us to assume that letrozole is a better drug than clomiphene. We published a paper in the British Medical Journal a couple of years ago where we grouped the drugs that we use for ovulation induction into various groups. So along this line, you get the higher pregnancy rate. Along this line, you get the lower multiple pregnancy rate. So Metformin, letrozole, clomiphene and metformin all have good pregnancy rates with low multiple rates. FSH, gonadotrophins, give you a high pregnancy rate, but also a high multiple pregnancy rate. And then you've got other drugs such as tamoxifen and clomiphene citrate. Gonadotrophins can be used by those who are skilled at monitoring and are still very valuable. And the standard accepted way of doing it now is to use a low-dose step-up protocol. And most IVF specialists and fertility specialists know how to do this well. But please remember, we only need one follicle and not many. So the main danger with FSH ovulation induction is overdoing it and getting high multiple pregnancies. Laparoscopic ovarian drilling is done by many gynecologists, and there is some benefit in its use. And finally, I want to talk about IVF and PCOS. So in PCOS, the high multiple pregnancy rate with ovarian stimulation is a problem. And with IVF, we can put back less embryos and reduce multiple pregnancy. It's often quicker when ovulation induction drugs don't work. It could be less expensive sometimes rather than continuing with ovulation drugs for a long time. But there are significant risks in inexperienced hands. And we still have this concern about whether IVF babies are as good as ovulation induction babies. So with IVF, we want to reduce ovarian hyperstimulation by using low doses of FSH, using good monitoring, using a GnRH agonist trigger with a GnRH antagonist monitoring, possibly freezing all embryos, and also maybe metformin may reduce the risk of ovarian hyperstimulation. If we have patients who have low LH, which is not common with PCOS, adding LH or HCG may be valuable. And finally, in my talk, I just want to talk briefly about educating ourselves and patients. This is the International Evidence-Based Guideline, which we published 2 years ago. You can get the full guideline, which is 350 pages, from this website. You can just put Monash PCOS into Google and you'll get it. And it covers everything that we and 37 societies around the world have agreed is the standard of care for patients with PCOS. We've also developed a PCOS app, which is available for Apple and Android, is free of charge and is evidence-based. And it's valuable for you and for your patients to be able to get the latest information on PCOS. We've also developed a model of care that we think is valuable for patients with PCOS. And that is the patient is central to the care and holds the management plan. But we need excellent specialists, such as you, to look after the patient. We need good allied health, psychologists and dietitians and possibly exercise physiologists. Where patients have GPs, they are very valuable in providing ongoing care in situations beyond that of reproduction. And finally, we need good education support and consumer support groups. And I have to say that PCOS India is by far the best group in the world in terms of educating doctors about PCOS. I really would like to congratulate you for the work that you are doing in India on PCOS education. And then we need to remember that this is a condition across the lifespan, that as the reproductive disorders are solved through menstrual disturbance and infertility, so we run into the metabolic consequences, which are complications of diabetes and cardiovascular disease later in life. So it's not just us as gynecologists that are important, but it's many other specialists. And where there is a general practitioner who's knowledgeable, they cover all of these, or the patient may need to go to individual specialists. So with that, I'd like to end my talk Thank you for your attention and hope that I've covered some of the concerns that you've got, and look forward to communicating with you in the discussion group that follows some of the questions and controversies that you wish to explore. Thank you very much. All right, I'm not sure how long that was, but it was probably about 40 minutes, was it?
Yes, sir. Exactly about 40 minutes. You have started with 310 and completed with 350. So your talk is about 40 minutes, and it was wonderful talk, sir. Thank you very much for having a wonderful discussion on PCOS. And I would request you to join at question answer session, the event which is held on 22nd of November. And I'll send your time regarding the session. You just need to attend for half an hour for any questions and answer, which is done by Indian doctors. We have finalized our panel. So after completion of session, we will have also the panel discussion on PCOS for Indian doctors. Okay, so they all will be joined at that time. And I think I just wanted to confirm with event team that the recording is now okay with Professor Norman. Yeah, Mintu?
Was the sound all right? Because there was a door that was banging in the background. I hope that didn't cause the trouble.
I think from my side, I think I have cleared your voice and everything. Your face is also cleared. Mintu? Hello?
Yeah, I can hear you.
Yes.